Hello, everyone, and welcome to this new TechNet 21 webinar series on EIR or IIS, how to select the best digital immunization system for your country context. Today, we're going to have an introduction to Tamanu and Samoa use case. You can listen to this presentation in French or Spanish. To do so, please select the globe at the bottom of the Zoom window and choose the desired language. If you struggle to find it, please do let me know in the chat area. Talking about the chat again, you can already introduce yourselves if you want, and you can tell us about where you're from and your name. We'd be really happy to know that. And you can also use the chat box if you have any technical issue, and we'll be here to help you with solving whatever issue you can have. And during the presentation, you can ask your questions, so don't hesitate. There's a Q&A box at the bottom of the window as well. Don't hesitate to ask your questions at any point. We will answer those questions after the session, after the presentation. There will be a Q&A session, and we'll take the time to reply to your questions. Finally, this session is recorded as per usual. I'll share the links to the slides as well as to the recordings by email, and they will be made available on the TechNet platforms. Thank you very much for joining us today, and I hope you'll enjoy this session. I'll give the floor to Michael, who will introduce himself. Michael, the floor is yours.
Thanks, Alex, and thanks to everyone involved in putting this together. It's really quite an amazing effort, how much goes into these things, and appreciate the opportunity to talk to a new audience. My name's Michael Noonan. I'm based in Melbourne, Australia. I run an organisation called Beyond Essential Systems. We're a B Corp based in Australia. We develop and implement e-health software, mainly in the Indo-Pacific, and with a real focus on Pacific Island countries. But we don't care where we work and interested in anywhere and everywhere really, but work solely in low and middle income settings. I personally have been working in international development for about 15 years. I'm a pharmacist originally, but have been working in e-health implementation for probably the last 10 years or so, maybe a little more. And today, yeah, talking about our electronic immunization record and electronic health record, Tamanu, with a Samoa use case. A bit of an apology at the start. My co-presenter, in inverted commas, Lenara Tupaifui from the Samoa Ministry of Health, is obviously based in Samoa, and it's just gone past 2 a.m. in Samoa at the moment, and Lenara works hard enough at the best of times. So we're actually using a pre-recorded presentation for Lenara tonight, and I will obviously be here to ask questions, but it's difficult to get time zones to work at the best of times, but in the middle of the Pacific can be quite tricky. So let's crack into it. We're going to talk tonight a bit of an overview of Tamanu to give you the context, and then talk about the use case from Samoa, and then hopefully leave enough time to do some Q&A. Hopefully I don't ramble on too much. For those of you who are not familiar with Australians, we really are not very formal people. So please feel free to interrupt me. I don't mind being interrupted, but I can't see the chat channel while I'm presenting. So if there's a particularly interesting point or someone would like to come off mute and ask that, I will not be offended. It usually makes for a better presentation anyway. This is the overview of hopefully what we'll get through tonight, just talking about the key functionalities, some of the considerations for implementation and your contracting options. As we'll touch on a few times, Tamanu is a completely free and open source software. Our typical contracting option is optional service level agreements, but we can talk about that a little bit at the end. Mainly though, we want to focus on the software, and we really do think that Tamanu is different. Obviously we would say that. It's possibly unique, but it's certainly very different to a lot of the options out there. And it's really built around 5 core principles that we considered fundamental. At Beyond Essential, we actually implement 5 different softwares, but only 2 of them are ours. And we don't develop software if we don't think that it's necessary. We implement AmSupply, which is a stock management system. We implement Senite, which is a laboratory information system. But for Tamanu, we set out quite a while ago in 2017, researching a software that met these 5 principles, because for the settings that we work in, these are the prerequisites. So far more important than any individual functionality or any sort of feature that you could add or all these sorts of things, the 5 sort of underlying principles to us were more important. And certainly in 2017, we couldn't find a software that met these 5 principles, and that's why we developed Tamanu. Now, I can't say hand on heart that I know that that's still the case. There may well be other softwares that meet these 5 principles, but we work in really, really low, we work in low resource settings. We work in highly remote settings. The Pacific Islands are a group of about 14 major countries in the Pacific Islands. Some of them are wildly spread apart. One example, we work in Kiribati. It's actually wider east to west than Australia, but most people couldn't place it on the map. So these are really disparate settings with relatively low digital literacy going into our projects. So we need to do things a little bit differently. So the 5 principles: free and open source, genuinely free and open source. Our source code for both Tamanu and Tupaia, which is our data product, all published online, and a permissive license. Desktop and mobile enabled out of the box. So we don't want to have to manage third-party integrations when we implement a mobile solution. We didn't want, a desktop EHR or EIR that is having to manage a third-party integration with a mobile data collection app. The two have to work as soon as you turn them on and pull them out of the box. Sync enabled / offline first across both desktop and mobile. This is really, really important to us. The settings that we work in lose internet connectivity all the time. Most of the solutions that you see these days, the mobile version is sync enabled and will work offline. We also needed our desktop implementations to be able to work as nodes at hospitals or islands or health centers, whatever, that regularly lose internet, sometimes for days or weeks at a time. So we need to be able to have complete flexibility in our networking to be able to set up a facility server on site, or for facilities to access, a web service via the cloud, or a mixture of both for a particular deployment. And that has certainly taken the most time. That's why it was about 2 years before we got even a basic version live with Tamanu, because building that sync engine took a really, really long time. The 4th principle, obviously, it has to be highly secure. And number 5, interoperable with compliant with HL7 We also have a custom API that we use for some integrations, but we have an HL7 Fire API that we continue to build out with each implementation, as well as configurable to any standard, so that if a country wants to use ICD-10, or if you're introducing ICD-11, or you're using SNOMED or CPT codes, or whatever the case may be, you can just plug and play with them rather than being hard coded to a single standard. So those are the 5 principles that it's built around, and as I say, we consider them to be fundamental in the Pacific, not everywhere. There are obviously settings that we come across where the internet is really stable, where digital literacy is much higher, and in those cases, Tamanu may not be the solution that you're looking for. Although we also stand by its features. We're very biased towards it as a system as well. The other thing to say about Tamanu is that it's not just an EIR. It's an EHR. It's a complete electronic health record. It has really comprehensive EIR modules, and you can use them as the only modules that you implement. We've got a couple of settings that do that. But it does scale out to be a complete EHR across inpatient and outpatient, as well as public health encounters, without any plugins or additional licensing or anything like that. And it integrates with Tupaia for mapping and reports. Tupaia is our sort of flagship software, which is an end-to-end data platform. Probably don't have too much time to touch on Tupaia tonight, but we can share some links at the end. As I said, complete flexibility in your network and your server deployment. And it's managed by us. So whilst it's a free and open source project, we get some community contributions. Honestly, we don't manage the developer community very well at all. And we should do a better job of that, but it is managed by us. We've got about 55 staff now across Australia, New Zealand, Fiji offices and then other sort of people dotted around the world. And Tamanu it's a digital square global good and has been for the last couple of years. These are the functionalities that it has. I'm going to give the quickest demonstration of all time, if I have time in a few minutes, of the basic interface. But as I say, we like more to talk to our principles than to individual features. Where a feature is requested, we've got a large software development team, about 25 full-time on our dev team, and we can turn around feature requests fairly quickly. Some cases in a few weeks with really urgent things, although typically, large new features take a few months. So we don't like to get hung up on what features we do and don't have, but obviously these are really important questions. I won't sort of talk through each one in this table. The ones that have an asterisk we do them to some extent, but not fully. So appointment scheduling we have, but actually auto-calculate functions will not automatically generate an appointment for patients. It will auto-calculate when your next vaccine is due, but it won't automatically create an appointment for you. We've also got a communication platform where you can, for example, be sent your vaccination certificate with a QR code, a visible digital seal on there, but it only supports email at the moment. We don't SMS patients. And there's a reason for that. We predominantly work in the Pacific and no countries have requested it yet because certainly not as a priority, because SMS is not really a secure platform of communication in the Pacific. People change their numbers often. They share mobile devices and all this sort of thing. The other things here, as you can see, not going to sort of read through them, but probably the one that stands out down the bottom is track and trace of vaccines via integration with GS1. We integrate fairly closely with MSupply. And MSupply, some of you will be familiar with, is a logistics management information system. It's a stock management system. We work with MSupply very, very closely. I'm on the board of the MSupply Foundation. We talk to them every day. And where it comes to tracking a commodity, we prefer to use MSupply, which is really built for that purpose. And then we integrate that with Tamanu, for example, sharing patient records and that sort of thing. Oh, sorry, there was one thing in that slide. So visualization through figures and risk maps, we do that through Tupaya. And if you want to see Tupaya, tupaya.org has a lot of our projects there. Although you won't be able to see most data, it's password protected. You'll see basically how the platform works. So this is the use case that we'll be talking about tonight, and Lenara will be presenting tonight. She is the Assistant CEO for Health Information, for Health Technology in, Health Technology and Communications in the Samoa Ministry of Health. She is a superstar in the Pacific and has done an incredible job in Samoa, implementing Tamanu, but also implementing a whole ton of other systems for their needs. So Samoa is a Pacific Island nation. It's in the Polynesian region. For those of you who are familiar with the three different ethnic regions of the Pacific, it's got a population of just over 200,000, about 215,000 across two main islands. It's a lower middle income country. It recently moved backwards from upper middle income to lower middle income. It's been hit extremely hard economically by COVID-19. Tourism made up a huge part of their economy. But it remained COVID-free until really late in the pandemic. In fact, they were well into 2021 before the first case of COVID reached the shores in Samoa. I may even have that late. It may even have been much later than that. They did an incredible job in keeping it out, but one of the last countries in the world. But the urgency and the need for the EIR had not just been demonstrated by COVID-19. Samoa had a measles outbreak in 2019 that killed 83 children, which is hard to get your head around. If the same ratio of children died in Australia from measles, it would be 14,000 children. So 83 children from a population of 218,000 was just devastating to the country. And from that point on, the culture around vaccination really changed. Pretty much every family was affected, and from that point on, there was a real sense that opting out was not it was not an option. So vaccination coverage rates have really gone up enormously, and then data requirements really went up enormously. But in 2019, one of the reasons for that is they had very limited data on coverage. They had different systems for different programs. They had sporadic internet access across the country. And as I said, lower digital literacy, not the lowest in the Pacific by any stretch. In fact, Samoa is fairly good by Pacific standards, but by global standards, Samoa has lower digital literacy. The system needed to handle both campaign and routine vaccinations. They didn't want a system that was just going to manage COVID vaccines or just going to manage a typhoid vaccine or whatever the case may be. They wanted everything in one place. They needed it to work offline on both desktop and mobile devices. They wanted a really simple, intuitive interface. We've got a full-time UX UI designer in-house at BES, but this is something that we're constantly trying to get better at and trying to do as well as we can to make it intuitive so that training requirements are really minimal. And they didn't just want an EIR, they wanted both a patient master index as well as a system that would eventually turn into their national electronic health record. Later on, they also requested international vaccine certificates with visible digital seals. My colleagues keep telling me to stop showing this slide. It's far too complicated for a rapid presentation, but for those of you who are interested, I assume we'll be sharing these slides later. We've included this. This is the network architecture, or I should say the tech stack for Tamanu. It looks quite complicated, but basically there's a desktop version, there's a mobile version, and somewhere in the middle of it, you need to put a central server. That can be anywhere. You can put that on the cloud. You can deploy it at a national data center in country, or you can deploy it on site at a facility. That central server then communicates via a compatible API with external services that you can see there, as well as some others. This is an example of our visible digital seal. We've issued a lot of these across a number of countries, not just Samoa. But we first developed it for Samoa, and you can see some of the features of it there. This is fully compliant with international standards and with the WHO standards on the VDSs, and it can comply with both the ICAO standard as well as the EU DCC standard. That's a configuration that you just set in the background to generate your QR codes. These are some screenshots from Tamanu. This is where I was going to look down. I think I've got about 1 or 2 minutes before we crack into Lenara's presentation. So I might actually do this and just see how we go and show you what this looks like on the front end. So I'm just running an emulator here to show you what entering a vaccine looks like on mobile. So we're logged in here. You can see Nicole Kidman. I created her earlier tonight to just demonstrate some things. So you can see that you can do other things. You can do diagnoses, you can do checkups, you can do referrals to other facilities, you can do lab requests. But what we're looking at tonight is issuing a vaccine. So you can see here that the vaccination schedule for this country is already loaded in. It comes up as a table. If you're too late to give a vaccine, it gives you decision support, preventing you from doing that and referring you to the catch-up schedule. You can skip past those warnings and administer it anyway, particularly if you're just entering an older record, but it does give you that decision support. Equally, if you try to give a vaccine too early, it will give you a similar warning and tell you when it's due. The dark blue is your sweet spot. That tells you that vaccine is due. Your yellow is you're running late, but you can still give the vaccine, and your light blue is you're a little bit early, but you are still able to give it. So those are your routine vaccines. You've also got your catch-up schedule, and then you've got your campaign schedule. And again, there's decision support built into this. So for example, if I try to give a second vaccine of AstraZeneca without having given the first one, it will give me a warning that I haven't given their first dose there. Equally, I gave this Pfizer vaccine, I think, I said it was yesterday, and it's warning me that they're not due to receive it for 3 weeks. Obviously, all of this is configurable, that decision support. So that's the front end. You can also use it to report adverse events. So these are configurable surveys that you can build very easily and import into Tamanu. One of them that we use as an adverse event following immunization reporting form, but there's other forms that you can use in Tamanu. We can control all of this by permissions, by the way. So if you are just a nurse that only gives vaccines, you won't see all of these other functions. You'll just see the things related to vaccines. And importantly, you can create patients on mobile with unique IDs. But in Samoa, that's turned off, which is probably a really good call because it saves them from having to do too much data cleaning. They had a really fairly good patient record, which Lenara will talk about in her presentation. But you can register new patients on mobile. The typical thing to do is to register them on desktop. This is what the desktop version looks like. So if we search for, let's log me out because of it will time you out if you leave it open on one of the wards. But you can pull up your patient, you can look at them there. Desktop obviously has a ton more functionality, labs, imaging, invoicing, procedures, all that sort of stuff. But you can just go up and look at someone's immunization record. You can view their certificate there. You can give a vaccine through desktop as well. It doesn't have quite the same levels of decision support because it's not presented in a table format, but you can, if you're a data steward, give your vaccines that way and it will capture the data in exactly the same method. So that is a really, really quick demonstration of what the system looks like on the front end, but I'm sure you are fairly keen to look at the presentation by Lenara. So I will hand over to her. As I say, Lenara is the Assistant CEO for Health, Technology and Communications for the Samoa Ministry of Health. This was actually recorded quite a while ago, I think about 12 months ago for a DFAT symposium. So some of the information in there is outdated around target populations and their vaccination rates and that sort of stuff. Samoa is now vaccinated over 90% of their entire population. So there's just some information that's out of date, but the basic information is all still there. So I will start it and hopefully you can see it.
When we started our COVID vaccination process, we foresaw a lot of challenges, and we also experienced a few challenges. For example, we weren't receiving all the vaccines at once, so we were getting them in portions. And when we did get the portions, the expiry dates was really close, so we were given about 2 months to have to use up those vaccinations and administer them before they expire. And one of the major challenges with Samoa not having a really reliable health information system to manage patient details was the lack of unique identification to identify them. So we currently had an information system that had a record of 800,000 population recorded. There was a huge number of duplicates. So it was not reliable information to use, especially when we were not given, when we did not have all the amounts of vaccines we needed in order to vaccinate the whole population. It was just the end of 2020, around November, where we also have a national ID project that's managed by the Samoa Bureau of Statistics. And we were very fortunate that they collected this information for the national ID purposes right when we were also discussing getting the vaccine for COVID vaccinations of Samoa. At that time, we were not sure the eligible population of an exact total population of Samoans in the country. And also we were not sure of how many people we actually had in the country that were eligible to be vaccinated. The data that was given by by the Samoa Bureau of Statistics was really helpful in helping us identify. Also during this time, Samoa had already activated its state of emergency processes and procedures. So there was very minimal traveling and immigration happening for people to travel out and travel into Samoa. We were having about 1 repatriation flight a month. So if the numbers changed, there was very minimal change in the population numbers. From that data, Samoa Bureau of Statistics collected 215,000 of the total population. And out of that number, about 121,900 were eligible, and the eligibility was counting those 18 years and above. The challenge was how to manage all that information in order for us to pick up our eligibility criteria and eligible persons. With that, we turn to Tamanu. Was there enough time to actually implement Tamanu in such a short period of time to ensure that we were able to manage the details? There was a little bit of doubt, but after a lot of discussions, we found that the mobile version was very user-friendly, very easy to implement, and it took us less than 2 months to get that on the go. With COVID, we were also very not so sure in the beginning, given the technical advisors for the system will not be able to travel in country. But then again, every challenge there's always an opportunity to grow. So we took on the challenge, and we did after a lot of online consultations and the Beyond Essential team working up into the late hours of the evening and early hours of the morning, meeting online and helping us with the system, we were able to have Tamanu desktop and Tamanu mobile up and running, and we were able to import the whole 215,000 population data into the Tamanu system. From that system, we were able to segregate how many of the population were in one island and how many were on the main island, which amounted to 24,000% or 24% in the big islands and 76 in the main island. This helped us a lot in planning how we were going to roll out our vaccination process. With the data now having villages on it, we were also able to depict these and indicate these on the Samoan map. We were also, our first strategy was to focus on the densely populated areas, which is also around the main town, main Apia area. And the other reason why we strategized to go with this was because this is where our main ports were, the main airport and the main seaport. So if COVID was to ever get into the country, it would be through one of these main ports. Hence, using Supaya and visualizing it on Supaya, we're able to pick out where of the country the eligible populations were getting vaccinated. And it was very hopeful when Supaya indicated that a lot of those living in the densely populated area were actually coming in to get vaccinated. And that was indicated by the orange-ish colors. Samoans are also very competitive. So the neighboring villages that saw their areas were still red did not wait for the vaccination rollout to come to them. So if you'll see on the bottom, some of the areas were already showing yellow or green before the vaccination rollout actually came to them. This was a very positive sign. As we were implementing and using these district level mappings, you will see that some of the districts were starting to get very high level of vaccination coverage. These mappings helped us and helped the teams reallocate our resources to where it is most needed. So once the area started turning orange or yellowish to green, then the neighboring district health facilities will reallocate their human resource as well as their vehicles or their staff to go to areas that were really red, which indicated very low vaccination, and then start vaccinating from there. Usually with intervention programs in the past years, we would all wait until a certain process was completed before you can compare the data and really decide on what you are going to, what strategy you're going to do to intervene and boost the process. But with the Tupaya mappings, this helped us within a few hours to decide on what the strategy will be the next day. So it was helpful and stressful at the same time, because sometimes viewing maps at night and then you'll get an email in the morning of what needs to be done. But then again, it really assisted hugely in boosting our vaccination rollout and our vaccination process. So at the end of every night, everyone is waiting online for the maps to be sent out. And I think we've, maybe Ashlyn has grown a few gray hairs, us pushing every night that we need the maps updated. The Tamanu system was also really helpful, because sometimes when it indicated to us when some villages have been red for so long, then maybe it's not because people are not coming in to get vaccinated. So we went around giving out, we printed certain lists from Tamanu and headed out to the community. And there we found that some of the people on the list were not in country. They left for seasonal work. Some of them have already passed away. Some of them are included in our exemption criteria, pregnant or 8 weeks and less, or a minimal amount refused, maybe just 0.something%. And some have actually gotten married or moved to a different village. But we did not pick up on those, as we have only been focusing on getting people to come in and get vaccinated. So that was the other level of reporting that Tamanu helped us with, identifying those people and then mark them on the system so they don't show up as a negative vaccination population on the mappings. Because no matter how many times you go back to get to vaccinate an RSE worker, you will never get them, as they are never in the country. This function was already inbuilt into the system, which was really great, because you can now do both vaccinate a person and also not vaccinate them, but identify the reasons behind why they were not vaccinated. So they are not depicted negatively by the community when they are picked up. With our data process, as Ashlyn has also presented on, we pride ourselves in that we were able to really train our nurses. Our non-technical staff have been the real champions in having this system being implemented. One of the things we really pushed is for the users of the system, especially the clinical staff, to be champions in the system. The IT people will just be there to facilitate and ensure that they are not frustrated with the system, but they have been the real champions in assisting us and helping us do the data entry, search for their own patients, and at the same time do their clinical duties, carry out their clinical duties. One of the things that Tamanu really helped us with was filtering each person on Tamanu using the existing data by households. So we were able, through the months, to know how many of the households in Samoa were fully vaccinated, how many were partially, and how many still had not had an eligible member vaccinated. With only 30,700 households in Samoa, this was a really helpful data in allowing us to know, because around August, we did a door-to-door vaccination process. And whether it was working or not, this data really helped us. And the 1st of August, when we just started, we had about 5,000 fully vaccinated households. Towards the end of last week, we reached about 11,000 fully vaccinated households. So that is one of the powerful information that Tamanu helped us pull out, and also really helped with our intervention programs. The system has also been very helpful, and I think one of the other things that had ensured success of the system was collaboration with other government ministries and organizations. If we hadn't done the data we got from the Samoa Bureau of Statistics, really was like a pre-registration of our total population. It would have been data that would take us more than a year to collect in order to finalize our eligible population and do a lot of calculations in order to get where we are today. But that collaboration really gave us the data that we needed to push our communities and all our non-clinical staff and clinical staff to really appreciate the system that was there. Also promoting awareness of our systems and building acceptance and confidence. Tamanu is a really user-friendly system. So, and one of the things we try to avoid is introducing a system that people will feel frustrated with using. But if you see from the photos, the staff have been really looking forward to mornings when we do vaccinations. The nurses are always the first ones to come and get their tablets, and always they want to vaccinate and enter the data at the same time, which is a very positive indication going forward, especially in health information systems, because then it makes our work easier in introducing the systems for them, and especially when they already start.
And apologies, that video cut off at the end, but there was only a few more seconds to go, so we didn't realize until tonight that we'd cut it at the wrong point. So that finishes Lenara's presentation, and it's a real shame that, as I say, she wasn't able to join. Very, very quickly, Lenara mentioned a couple of times, and I mentioned Tupaia. Tupaia is fully integrated with Tamanu, so we do a lot of our reporting and visualizations through Tupaia. This is what it looks like now in Samoa. They've gone extremely well with their vaccination campaign since then, and as I say, I think they're over 90% now for their total population. So I might stop there and hopefully leave some time for questions. I'm happy to demonstrate more or sort of get more into the weeds of the system architecture and the tech stack, but also just trying to balance what people might be more interested in. So I'll pass over to you and
okay,
and see if there are any questions.
Thank you very much, Michael. I see that you answered some questions in the Q&A box, but I will let Harriet and Emily decide if they deserve to be answered orally, because the session is recorded and will be watched anyway by more people who registered and couldn't join today. So Emily, Harriet, the floor is yours.
Thanks, Alex. That's kind. I think maybe if we just, quickly go through those answered questions so they're all captured. And if we don't get any more questions, then Michael, it would be great for you to do a bit more of a demo, and feel free also to demo some of the answers. That might be a good way forward. How does that sound?
Yeah, absolutely. So the first couple of questions are kind of related in a way. How efficient is Tamanu in terms of immunization defaulter tracking? Like with all systems, this is only as good as your denominator data. So Samoa was quite lucky in this respect. They've just recently, as in recent to the COVID outbreak, COVID pandemic, conducted a complete census of the country and had really granular information about more than 95% of the population. So we were able to track defaulters pretty much from the start. And in Samoa, we were able to do that right down to the individual household level. Each day, teams heading out could be, particularly when they got to the mopping up campaign, were able to be given really, really highly detailed maps of where they needed to go to do their campaigns for that day. Obviously, household level data is fairly sensitive information to be sharing. So there was only a small handful of people at the ministry who actually had access to that data, and then they would provide to the district teams just information that was relevant to them. So they kept a fairly tight rein on that data, but it was hugely useful for tracking down. Sorry, I should say that's far more relevant to tracking down zero doses, where your denominator is quite important. For your immunization defaulters, same thing. We're able to produce reports again at a quite granular level of people who've had a first dose but haven't presented for their second dose or later on for their booster, and we can disaggregate those reports by village, by district, by island group. We can also support multiple data hierarchies. So there's a lot of flexibility around how those reports are done. We can also produce them as line listed reports in Tamanu and just export them straight to an Excel spreadsheet, or you can produce them as customized visualizations into PIA, and we've got quite a lot of them these days. Then there was a question around tracking vaccine accountability. So you can track basic things in Tamanu for the individual patient. So the batch, the expiry, the VVM status for an individual product, the manufacturer, the fields that you collect when you're giving a vaccine are fairly configurable. You can track, you can record consent, you can record was there a parent or guardian or DNA, those sorts of things. When you're talking about actual commodity tracking, so your quantification, your tendering, your warehousing, live temperature tracking, distribution and transport, all those sorts of things, we recommend that you use MSupply for that, which is a dedicated stock management system, and we then integrate it with Tamanu. So that's what they do in Samoa. It's what they do in a couple of other places. We can share a patient record, for example, between those two systems, it just means that we're not sort of reinventing the wheel with the functionalities that we build in Tamanu. And the final question there was that how do you search for patients in the mobile app? So this really goes to the heart of how our sync model works. So the way that it works is that every single node, whether it's a mobile device or whether it's a facility server that's based out at a remote hospital or whatever the case may be, they store every single patient on every single device, but not all of the details for those patients. So they store first name, last name, date of birth, sex, home village, and ID. And you can search using any of those parameters to find your patients. Once you've found the patient that you're interested in, you've found Nicole Kidman, she's never been to your facility before, but you would like to administer a vaccine to her, you can mark her for sync. Now, if you are online, if you have an internet connection, just notice my video has gone a bit funny. I was looking a little bit blurry. If you have an internet connection, you can sync down her entire record right then and there. And actually, as part of that, and we built this for Samoa, their vaccine records also remain in sync. You can then give your vaccine and that will sync up. If you're offline, you can still pull up Nicole Kidman's basic details. You can see that interface to enter data. You can issue a vaccine. You can enter any other data. You can make a diagnosis or submit an adverse event report. And when you've find an internet connection, it will sync up automatically and mark her for sync in the future. Once a patient is marked for sync at that facility, they're considered to be a patient of that facility, and any encounter that that patient has at any other facility, that information will automatically remain in sync on that device, so that for the vast majority of patients in the country, you don't have their full medical records on your device, you've just got their basic details. But once they're marked for sync on your device, you will be able to access their complete medical record offline. So I hope that explains it. The same is true across desktop sites as well. We spoke about fully vaccinated household. So what Samoa requested, although we could have done anything, we could have shown partially vaccinated households. We have information on partially vaccinated households. What Samoa really wanted was show us on the map every household where every single adult in the household is completely unvaccinated. So we called that an unvaccinated household. A fully vaccinated household was a household in which every single adult in the house had 2 COVID vaccines in that case. Tracking all of those became just a huge cluster of dots that were sort of meaningless because once they were vaccinated, they were vaccinated. What they really wanted to target was the unvaccinated groups. Then, do you actively follow up through Tamanu on children eligible for the next dose in terms of sending SMS reminders to caregivers, an example? So the question around SMS and WhatsApp, honestly, is a question we get from donors far more than we get from the countries that we work with. But we've been asked about it enough that we are trying to get it done by the end of the year. We used to support SMS through a system called Rapid Pro SMS. It wasn't being used, and we haven't supported it in a while. We're going to bring that back, probably starting with WhatsApp and Messenger integrations before we go to SMS. The problem with SMS in the Pacific, and I can't speak to the rest of the world as well, is that people change their mobile numbers so often. I don't know why. I've worked in the Pacific for about 15 years, and I don't know why this phenomenon exists so much. But people change their SMS a lot, and it's not considered a particularly secure form of communication. People also share mobile devices across an entire household, or an entire household might have a couple of devices that get shared around really flexibly. So the countries that we work with are far less focused on this. That said, we support email notifications for example, COVID testing. We've sent out over 300,000 automated emails for people's COVID test results across a number of countries. We can also send out, as I say, vaccine certificates via automated email. So we have automation in the system for emailing patients that we implement on countries' requests. But we haven't been requested to send out SMS reminders to caregivers yet. But it's a functionality that we hope to have, if not by the end of the year, then very early next year, because I think the use of it will expand even in the Pacific, and it's certainly something that's obviously really, really important, or more important elsewhere.
Hey, Michael, thanks so much for answering all of the questions in the chat. I do have one around what your comments around the EHR, and that Tamanu could be also built out for an EHR. So I'm wondering if you've developed a roadmap or any sort of formal support processes to move countries from an EIR to an EHR, if that's where they if that's where they want to go. Thank you.
Yeah. So, I mean, we've got quite a long and ongoing project in Samoa that will stretch on for another few years in scaling up their EHR. The timeframes for implementing an EHR are obviously a lot longer. Even a basic hospital implementation, we usually tell countries that it's about 6 months once the project managers are on the ground. People may presume that's just a training thing. Training is a huge part of it, but it's really, really important to map their current state workflows, to map their future state workflows, to configure the system so it meets their needs, to load all your reference data in. So what sets of standards are you going to be using? we've got about 35 data sets that we need to load in before the system goes live as a full EHR. So that ranges from your diagnoses lists, so your lab tests, your lab test types, your imaging types, your procedures. There's 35 different sets of information that we need to go through and work with countries on doing. And we have really detailed project management tools for that we're always happy to share. All our training materials are online as well. When we do that, as I say, we typically end up with countries using a mixture of mobile and desktop, but on desktop, we've got fairly comprehensive functionality, emergency department, wait list automation, imaging requests, lab requests, immunization registers and tracking campaigns. And then for individual inpatients, really quite comprehensive functionality around patient notes, loading documents against a patient record, programs, medications and prescribing discharge records. So it's really comprehensive, and it's all baked into the system already. But if you just want to use it as an immunization record, we can turn all of that off. We can make sure that none of your staff have permission to do anything with that, and you can just use it as an EIR. But typically the countries that we're working with, because we're not replacing digital systems, we're often replacing paper. And even where we are replacing digital systems, they're looking to integrate those systems into one, so that there is a single birth to death record for all your encounters with the health system. And so typically that's what they like us to do. But yeah, you can do everything. You've got your WHO patient death record, which is according to the WHO standard. You can track everything, allergies, family history, all those sorts of things that you would expect. But it's a much longer time frame. So we've got a go live for a partner country coming up in about 2 weeks, and our project manager's been working. That's at a single hospital, and the project manager's been there for about 6 months planning that. So it's a bit more comprehensive. I should say, as a really fundamental thing, we're really serious about this idea of love the software but don't like us. It's genuinely free and open source, and we are really open to other people coming along and implementing it. We're very lucky to have funding support from a couple of donors, DFAT included, and that's long-term funding support, so that we're not relying on selling licenses or having this as a software as a service. If you have an implementing partner you'd prefer to work with, or you are an implementing partner and you're looking for software, you can have all of our training documents. You can have all of those project management documents. We're really just happy to see it having an impact wherever it gets used.
Thanks so much, Michael. I think there's another question in the chat, a new one.
Oh, the unique IDs. Yeah, so the unique IDs is an interesting one. So Samoa uses we've got an out-of-the-box system for generating unique IDs. It's a 4-letter, 6 numerical characters system. So you end up with 10 characters. That guarantees uniqueness. And you can generate those in the field even offline, so that if a patient presents and you have no record of them or can't find a record of them, you can generate a unique ID in the field. The default system, as I say, is the 10-character system, but you can actually change it so that you can have more or less characters. You can also have rules. So if the first 2 characters are a particular letter set based on the facility and that sort of thing, you can build rules into how those unique IDs get generated. But of course, we've also got countries that already have coding systems, and patients already have IDs. And in those cases, we just import the set initially, and that becomes the patient's ID. So we also support that. Most of those countries don't allow the patient IDs to then be generated in the field because they've got a central system. some, but not all of our countries use Tamanu as their PMI, and that's probably a whole nother topic of conversation. But we have fairly comprehensive tools for a patient master index, including now an HL7 FHIR compliant API to share that data to external systems, but the ability to merge patients, the ability to import patients, edit patients, control the permissions of who can import, create, and edit patient records. So you can use it as a PMI as well. I also noticed that someone from Simprints was on the line. This is on my to-do list, is to go back to Simprints, who we've had some very, very preliminary discussions with, but we really like their tech, actually. So not to spruik one system over another, but our discussions with them have been yeah, really interesting and really productive. So hopefully sometime next year we can also get a biometric integration going with Simprints or someone else. But yeah, we've certainly enjoyed our conversations with them so far.
Thanks very much, Michael. I think that's all of the questions, unless anyone quickly wants to drop another question in the chat. If there's anything you wanted to demo quickly, Michael, in the last couple of minutes, then feel free.
That's okay. I might really quickly type in a couple of links for people to check out the system if they would like. I should have had these ready to go, but I can just type them in. Tamanu. So that's Tamanu. Some of you will have seen tapaya.org. I should put in the full URL. Tapaya.org. If you're already using a system, an EIR, tapaya.org integrates with a whole ton of other systems. So tapaya.org doesn't need Tamanu and vice versa. Tapaya's another free open source system, and it is designed to complement existing systems. So DHIS2, mSupply, or anything else you're using. We've got a Kobo integration that we do in Laos, for example. It's not a health project, it's an education project, but yeah, the data broker on Tapaya is really quite flexible, and it's, yeah, we're quite proud of it. But otherwise, yeah, we've also got a YouTube channel which has got a lot of demos on there, including of the vaccines module. So for people looking for more on it, I should find the link for that as well. And
okay, I think
quickly share that.
Yeah, I think, Michael, that would be great if you could send me by email all the links so that I can include them in the mail that I will send to all people who registered to this session, and as well with the links to the recordings and the slide. So so all the links will be shared with everyone here and other people who couldn't join by email. Okay, thank you very much, Michael. I think we're on time. Thanks so much for this presentation on Tamanu. And well, what does Tamanu mean? Sorry if you said it, perhaps.
No, it's a really good question. I should have said it at the start. So Tamanu is a therapeutic plant that's used really widely in the Pacific, very commonly used in countries like Fiji for a range of therapeutic uses. Tapaya is was a Polynesian navigator, actually joined Captain Cook's crew in 1769 as Endeavour came through the Pacific and was able to map the Pacific better than the Europeans could at the time. So it's named, Tapaya is named in his memory, and Tamanu is really just a tribute to indigenous therapeutics. Excellent.
Thank you very much for this explanation. So thanks again, Michael, for this presentation. And as I said just before, we're going to share the recordings and the slides and by email. And yes, please, Michael, just send me by email. If you don't have it, I will drop you a mail and all the links that you want me to add. So to the YouTube channel and so on. And everything will be sent to all participants and people who registered and couldn't join today by email. We hope everyone enjoyed this content. I did. We hope to see you all next week for the 5th session of this series. If I'm not mistaken, this is an overview of ComCare as an EIR IIS with the Jamaica use case. In the meantime, I wish you all a nice week. And Michael, good night, because I think, what time is it for you there?
It's just gone to 1 a.m.
Oof. So good night, and thank you very much, Harriet, and thank you very much for oh, I think just give me a second. Yeah, so thank you very much, Harriet, and thank you very much, Emily, and I would like to thank also our interpreters for the good work. Have a nice day, everyone, and good night, Michael. Bye-bye.